I'm Thomas Baldrick here at ATS in Denver 2015. Happy to have with us Dr. Mardi Gomberg-Maitland. She is the Director of Pulmonary Hypertension Program at the University of Chicago. Thanks for taking a few minutes with us. So you were involved in an oral presentation on genetic variants in clinical outcomes. What can you tell us about this?
Sure. So this has been a study that's been in progress for quite some time because my colleague and friend Ray Benza had an NIH grant to look at patients on endothelin receptor antagonists and to see if there was any genetic susceptibility for patients to have a better response to these medications. So really looking at genetic pharmacogenomics, or I should say pharmacogenomics of PAH therapies. And so he had over 1,000 patients in multiple clinical trials. Patients were investigators around the US and worldwide gave him samples from patients that were on endothelin receptor antagonists. And so he amassed over 1,000 samples. The reason how I got involved was because I had a grant from the Pharmacogenomics Research Network to look truly at pharmacogenomics. And through a collaboration with Riken in Japan, we were able to get all of our samples GWAS'd. And through the GWAS, we actually looked to see if there were any associations with what we defined as poor clinical outcomes or clinical worsening. And so what we found was that there are some SNPs and chromosomes that are likely linked within the pathophysiology and pathobiology of pulmonary hypertension to patients that have better or worse outcomes. And so it's really the first step to taking genetics and the pharmacology and really melding it together in pulmonary hypertension.
What were some of the highlights of the presentation?
Well, I think that this is one of the first ones with really addressing pharmacogenomics, I think nobody knew what to expect. I think people were quite surprised that there really was some linkage and that we might be able to in the future target therapies to the actual genome of the patient, similar to how they're doing with cancer pharmacology and outcomes, which would be great. I think that it was interesting to see that it's really, if you were homozygous, that you had worse outcomes, and so we weren't expecting to really pick up anything. In the field of genetics, 1,000 samples isn't a lot, but in the field of pulmonary hypertension, 1,000 samples is a lot because it's an orphan disease. So I think that this was really to show folks we're moving this field along. We're not there yet, but we all need to collaborate together in order to be successful.
So with this, you've got a good foundation. What comes next?
I think the next step would be to try to validate it in another cohort, which isn't easy because you don't just need the samples, you need really good phenotypic data. And phenotypic data is really the clinical data that's associated with the individual patient in order to determine if there's really truly reasons why. It's not just the genetics, but also if we could actually identify these patients in clinic without genetic sampling, that would be high risk. And so how are we going to do that? I think we're going to probably have to reach out to folks in Europe in order to do that. Or maybe it's just that it's enough to start and we need to just really look at the actual results that we got and really only try to focus on those genes.
Well, we wish you the best and appreciate your time.